So, a very good morning, everybody. Uh, the topic of my presentation is oral steroids in retinal vein occlusions. So, like, firstly, we'll see few of the cases. Like, here is a 61-year-old hypertensive who came with the complaints of diminution of vision in the left eye for the past 2 weeks, and the vision in the left eye was 618, and anterior segment was normal. And then the fundus in the left eye showed superiotemporal branch retinal vein occlusion with macular edema. And then, like, as a classical treatment of vein occlusions is like if there is any associated macular edema, we usually inject an intravitreal anti-VEGF. Or if no macular edema with associated neovascularization, we do a sectoral laser photocoagulation. So, like, this was the treatment. Like, firstly, like, actually he received an injection, and then, like, in actually luckily first month post injection the edema got resolved, and then again at 3 months the edema recurred back. So, and then again he received an repeat injection, and then we like actually we had to give actually 3 doses of injections. So, and then this is the case 2, likely wherein a 59-year-old diabetic, like, who came with diminution of vision in the right eye for the past 1 month, and the vision in the right eye was 6/12, and anterior segment was normal. Fundus showed right eye superiotemporal branch retinal vein occlusion, and then like again the plan was to inject intravitreal anti-VEGF. So again, like, we had to give actually 3 injections. Still the edema did not resolve. So, like, what are the limitations of anti-VEGF injections? It's only like, it will usually treat the manifestations, but like, and prevent the late complications. Does not really act at the basic pathology, and then we'll need multiple injections, which is also troublesome for the patient. So, like, is there a way out? So, and then we wanted to evaluate the efficacy of oral steroids in retinal vein occlusions, like both central and branched. So, and then the parameters considered were the visual acuity, central macular thickness, and then the vascular remodeling. So, like, all patients diagnosed with central and branch retinal vein occlusions after fundus evaluation, the BCVA was recorded, and then, like, all those patients underwent radial macular 9x9 mm OCT scans for central macular thickness, and then fundus photos were also captured. And then, like, after a thorough systemic evaluation for oral steroid contraindications, was started on oral steroids at 1 mg per kg with actually 10 mg weekly tapering. And then those with uncontrolled diabetes, like active systemic infections, and then actually pregnancy and actually postpartum patients were excluded. And then, like, we'll see few of the cases who were treated with oral steroids. Like, here is a 53-year-old hypertensive who came with diminution of vision in left eye for 5 days, and then the vision was 618, anterior segment was normal, fundus showed superiotemporal BRVO with CME. And then the patient was started on 60 mg of oral steroids with weekly tapering, and then, like, almost for 2 to 3 months the patient is still actually stable. So, and then here is a case 2, a 48-year-old with actually diminution of vision in the right eye with vision of 6/24, and then the fundus showed superiotemporal RVO with CME. And then again the patient was actually started on 50 mg of oral steroids with weekly tapering, and then almost actually 2.5 months the patient is still maintaining stable. So, and then this, so, and then the left side is a patient to actually begin with, and then at 4 months this is the fundus and the OCT. And then, like, here is a case 3, who's a 47-year-old, like, who came with diminution of vision in the right eye, and the vision was 660, and the diagnosis was CRVO with actually cilioretinal artery occlusion. And then the patient was actually planned to start with 60 mg oral steroids. And then actually this is a case 4, like, so, and then we can see, like, at presentation the vision was 660, and then, like, actually 2 months later it was actually 69, like, who was treated with oral steroids. And then this is a case 4, a 53-year-old with with central retinal vein occlusion with CME, and then like, again the patient was treated with 70 mg per day oral steroids. And then even oral steroids can aid in actually vascular remodeling as well. So, like, this is actually like one of the case of central retinal vein occlusion with CME. And then this is the actually fundus photos, like actually sequential fundus photos after starting on oral steroids. So, and then this is and then again this is one of the impending case of CRVO. And then we can see the actually vascular remodeling. like over the course. And then this is a case of central retinal vein occlusion with actually cilioretinal artery occlusion. So like this was a fundus photo at the time of actually presentation, and then this was almost a month later, and then this is almost actually 3 months later. So like again, this is one of a case of central retinal vein occlusion. Actually the left side is at the time of the presentation, and then the right side is almost a month later. So and then the results are, we had actually 12 cases in total, like 8 were branch retinal occlusions, and 3 were CRVO, and then 1 was CRVO with cilioretinal artery occlusion, and then 7 being males and 5 being females. Like all 12 patients showed significant reduction in central macular thickness as well as improved vision. And then all 4 cases of CRVO showed significant vascular remodeling, in the due course. And then actually 3 patients had recurrent CME, and then like we had to actually resort back to like injecting anti-VEGF. So like the discussion is like alteration by any factor like inflammation in most of the cases, like in as described in actually Varco's triad, actually can lead to actually vascular insult. Like oral steroids, like will aid in remodeling the vascular insult, insult if instituted at an early stage of the pathogenesis by decreasing the inflammation. In most of our patients on oral steroids, we could prevent multiple intravitreal injections, including anti-VEGF and also steroid injections. And in those who were previously treated with anti-VEGF or Ozurdex and like had recurrent CME, like we had initiated with oral steroids and then like decreased the need for the multiple injections. Like I mean, it increased the frequency of the injections, like but we couldn't avoid it fully. So and then the conclusion is oral steroids is an effective treatment option for all types of retinal vein occlusions. However, systemic evaluation and excluding those with contraindications to oral steroids is equally important. Thank you.
Good morning, everyone. My topic for today's presentation is clinical study of hypertensive retinopathy in patients with cerebral stroke. Hypertension is the most significant modifiable risk factor for stroke and a major public health concern. Therefore, amongst hypertensive patients, it is imperative to identify the individuals at risk of stroke. Assessment of cerebral stroke vasculature is important in determining an individual's risk for stroke. The retinal vasculature is unique in that it can be directly and non-invasively visualized in vivo and displays cumulative changes in microvascular circulation. Retinopathy changes in the eye due to hypertension is a chronic process resulting pathological changes that occur in the retinal choroidal and optic nerve circulation are all in response to elevated blood pressure, resulting in retinopathy changes in these structures. The intracranial and optic vasculature system share similar anatomical, physiological, and embryological characteristics. They possess a blood-retinal barrier which is identical to the blood-brain barrier, and the retina being an extension of the diencephalon. Thus, we could hypothesize the changes in the cerebral vessels could be similar to the changes in the retinal vessels. Hence, a fundoscopic examination of the retinal vessels may provide an opportunity to understand the intracranial vessel changes and the development of stroke secondary to hypertension. Aims and objectives. The aim of this study was to study the hypertensive retinopathy in patients with cerebral stroke, and the objective was to select the patients with stroke diagnosed with hypertension and find the grading of hypertensive retinopathy in these patients. Materials and methods. The study was an observational, descriptive, cross-sectional, hospital-based study with a sample size of 25 individuals. The period of study was January 24 to March 25. A total of 25 patients were evaluated based upon detailed history and fundoscopic examination after taking their consents. The inclusion criteria of the study was patients admitted for cerebral stroke diagnosed with hypertension and the patients who were willing to participate in this study. The exclusion criteria was the patients diagnosed with other retinal pathologies other than hypertensive retinopathy and pediatric patients. Result of the study was amongst 25 individuals, 5 individuals had no signs of hypertensive retinopathy. Grade 1 hypertensive retinopathy was seen in 14 patients. 3 patients had grade 2 hypertensive retinopathy and 3 patients had grade 3 hypertensive retinopathy. No patient with grade 4 hypertensive retinopathy was found. So the distribution was patients with grade 1 hypertensive retinopathy were 56%, no retinopathy 20%, grade 2 12% and grade 3 12%. Distribution based upon gender. Out of 25 individuals, 14 were males, that is 56% were males and females were 44%. Distribution based upon age. Between the age group of 31 to 50 years, the patients were 4, that is 16%, 51 to 70 were 60%, and 71 to 90 were 24%. Discussion. This study was conducted in cerebral stroke patients diagnosed with hypertension. A positive association between cerebral stroke and presence of hypertensive retinopathy was noted. There have been many studies conducted previously where a correlation of retinal microvasculature and cerebral stroke was investigated. According to our study, the average age of the patients with cerebral stroke was 61.5 years, which was similar to the study conducted by Chen X et al., which was 63.3 plus minus 7.3 years. According to a study conducted by Wang Z et al., among the different severity grades, their study had maximum patients with grade 3 and grade 4 hypertensive retinopathy, but in our study, the maximum patients had grade 1 and grade 2 hypertensive retinopathy changes, which was similar to a study conducted by Park S.H. et al. As mild hypertensive retinopathy was the most prevalent grade, there were no patients with malignant hypertensive retinopathy changes. Moreover, we examined both eyes of the study participants and grading was considered of the worst eye. This minimized the chances of missing any retinopathy. Focusing solely on non-diabetic individuals and meaningfully hypertensive retinopathy grades, the study offers strong data and a risk model that enhances clinical assessment and decision making. Conclusion. Hypertensive retinopathy serves a clinically relevant biomarker reflecting systemic microvascular damage and is independently associated with an elevated risk of cerebrovascular events, particularly stroke. The findings underscore the value of fundoscopic evaluation as an accessible, non-invasive tool in the vascular risk assessment of hypertensive individuals. Integrating retinal screening into routine hypertensive management protocols may enable earlier identification of the high-risk patients and inform targeted preventive strategies to mitigate the stroke burden. Thank you.
A very warm good morning to everyone. Today the topic of my presentation is assessment of diabetic retinopathy, macular edema patterns and biomarkers on optic coherence tomography in diabetics with and without nephropathy, a comparative cross-sectional study. Our aim is to evaluate the severity of diabetic retinopathy and assessment of the macular edema in patients with diabetic nephropathy. Objectives are to assess the severity and to compare with the patients of diabetic retinopathy. There are 65 million adults in India currently suffering from diabetes mellitus, and by 2045, that number might be projected to reach over 130 million. That is a complete pandemic sort of a thing, and the rate of the vision impairment and the blindness from these conditions will rise. In India, 5 to 7% of diabetics, or 3 to 4.5 million individuals, have sight-threatening diabetic retinopathy. Our inclusion criteria for the study are diagnosed proven diabetes of type 2 diabetes of any duration, diabetic retinopathy with or without macular edema. Exclusion criteria is gestational diabetes mellitus, pregnant women, UTI, heart failure, or any condition confounding proteinuria. Ocular media is hazy enough to preclude the examination and assessment of diabetic retinopathy. Glaucoma or age-related macular degeneration, cataract, retinal surgery within last 3 months. Macular edema of etiology other than diabetic retinopathy. Anti-VEGF received within last 3 months. Intravitreal steroids received within last 6 months. PRP in last 3 months. It is a cross-sectional comparative study. All patients are taken within a period of 1.5 years, presenting in opthal OPD in collaboration with nephrology and endocrinology department. The study sample size of 52 patients in each group. Informed consent was taken, blood investigations were done. Spot urea albumin creatinine ratio was used to categorize albuminuria. Classification into group 1 and group 2 was done. Best corrected visual acuity was recorded. Fundus examination. Indirect ophthalmoscopy and color fundus photography was done. And OCT was done to assess morphological patterns and OCT biomarkers. Analysis, primarily the patient without diabetic retinopathy seems to be in an older group with a mean age of 62 years. And the duration is more in patients with diabetic nephropathy with a mean of 14 years. And eGFR is more in without diabetic nephropathy as obviously required. In moderate and severe NPDR, mostly there are patients without nephropathy, and patients with nephropathy usually presented to us with very severe NPDR or high-risk PDR conditions. And logMAR BCVA was more in cases with diabetic nephropathy patient, that is, they have worse visual state. And mean central subfield thickness was comparative with the p-value of 0.93, that is almost equal in both the groups. Patterns of diabetic macular edema was noted. There was, in patients with diabetic retinopathy, the most common came out to be spongiform. Second most common was cystoid with 29%. In patients with diabetic macular edema, in diabetic retinopathy with nephropathy, the cystoid group is the most common, presenting to us with 41%. And second most common is a mixed pattern. Then biomarkers on OCT were done. The most common in patients with diabetic retinopathy, it came out to be hyperreflective dots and disorganization of inner retinal layers. In patient diabetic retinopathy and nephropathy, the most common group was disorganization of inner retinal layers and bridging retinal processes. So for the conclusion that we have found that the ocular findings in patients with diabetic retinopathy with nephropathy, there is worse visual acuity, higher prevalence of advanced patterns of diabetic retinopathy, and diabetic macular edema, notably more cystoid and mixed pattern, more severe OCT biomarkers such as bridging retinal processes and disorganization of inner retinal layers. Central subfield thickness was not significantly different between both the groups, including the macular thickness alone may not distinguish between these two groups. These are my references.
Good morning, one and all. I am Dr. Ashutosh. I would like to present the case on unilateral vision loss with contralateral prophylactic trabeculectomy. Introduction. Rubeosis iridis is characterized by neovascularization of the iris. It is a slight light-threatening complication associated with the various retinal vascular diseases, including CRVO. Hypertension is a known risk factor for the CRVO, further emphasizing the need for the careful management of blood pressure in this patient. Here, I am going to report a case of a rubeosis iridis secondary to unilateral CRVO in a middle-aged female with hypertension. A 75-year-old female present to IOPD with complaint of gradual progressive painful diminution of vision in both eyes for 7 days associated with watering and redness. She had no significant past history. She had a history of hypertension for 4 years, was on irregular medication, and no such other significant past history. General examination, Her blood pressure was 160 by 100 on 2 occasions of 12 hours apart. Rest systemic examination was normal. Ocular examination. She presented us with no perception of light and absence of projection of ray in all 4 quadrants. She had congestion in her conjunctiva, and cornea showed stromal edema, KPs, circumciliary neovascularization, and nebulomacular opacity centrally. Anterior chamber was shallow. Iris showed neovascularization of iris. Pupil had RAPD. Lens, she had a cataractus lens of NS1 grading. Her IOP at presentation was 66 mm of Hg. Left eye was assumed to be normal. On further evaluation, found to be a glaucomatous. These are the anterior segment examination showing the 360-degree neovascularization of iris at angles as well as the 360 surrounding the pupil. Fundus examination showed full cup. Vessels were highly tortuous and showed dot blot hemorrhage and cotton wool spot. Investigations were done. Blood investigation was within normal limit. USG carotid showed no atherosclerotic changes in carotid vessel. There was no plaque, no stenosis. ECG and 2D echo were within normal limit, and lipid profile was within normal limit. B scan of the both eyes were normal. Diagnosis. Based on a clinical finding, we diagnosed it as a rubeosis iridis secondary to unilateral ischemic CRVO. Patient was managed medically first and was followed for 4 to 6 months. On presentation, patient showed KPs, stromal edema, and had IOP of 65 mm Hg. We planned for a PI and medical management, which got reduced. Her IOP got reduced to 35, but it was not well within the limits. So we planned trabeculectomy for the left eye, which was the only eye. Then these are the gonioscopic findings. Thank you.